Caitlin. Hi, everyone. My name is Kate Holmes. I'm a member of ASHA, and I have the pleasure of just facilitating today's webinar. So we're going to jump right in. So for those of you who are maybe new to the American School Health Association or maybe haven't joined a webinar of ours before, the American School Health Association is a multidisciplinary professional membership with a strong focus on, obviously, school health. And it's really focused on healthy students, safe and healthy environments, and kind of getting engaged with all those champions and all those folks who are working in that space. If you are not a member of the American School Health Association already, I strongly encourage you to join. I've been a member for many years now. And as you can see on the screen, there are a lot of benefits to joining, including access to the Journal of School Health, which is a wonderful resource, continuing education credits, discounts. But, you know, for me, the biggest piece is the information and expertise. So webinars like this, the annual conference, which actually just passed and was one of the best conferences I've been to, some of the best keynote speakers I've ever heard. And so again, if you are not a member of ASHA, strongly encourage you to join, but also are just glad that you're joining us here today. So with that, I'm going to jump in to introduce our presenters who are presenting on a strategic process to create comprehensive health and wellness plans. We have three presenters who are sharing their information and expertise with us today. So first is Dr. Benjamin Ingman. Dr. Ingman is a research professor and director of research and evaluation in the Center for Rural School Health and Education at the Morgridge College of Education at the University of Denver. He currently directs the Working to Improve School Health project with Elaine Belansky, who's also joining us today. And his research interests include school health, university community partnerships, adventure education, curriculum studies, and educational experience. I love the concept of adventure education. So I'm excited to have Dr. Ingman with us today. Dr. Elaine Belansky, who's also joining us, is the director of the Center for Rural School Health and Education, also at the University of Denver's Morgridge College of Education. Elaine has a PhD in social psychology and over 20 years of experience developing strategies to shorten the time it takes for rural schools to implement evidence-based practices shown to increase students' health. And last but not least, we have Carla Loecke, who has worked in the field of school health and wellness since 2012. She's currently the Director of Curriculum and Training at the Center for Rural School Health and Education at the University of Denver. And she has a background in elementary education and taught sixth grade for 5 years prior to joining the team at CRSHE. So at this point, I'm going to pass it over to them to share their expertise.
Thank you so much and welcome everybody. We're so glad that you could be here today to join us. We're going to talk with you today about a strategic planning process that we've used for creating comprehensive health and wellness plans in schools. And three of us are going to be speaking with you today. You've just heard our introductions. I'm Elaine, the Executive Director of CRUSH. That's what we call the Center for Rural School Health and Education. Ben, he's the Director of Research and Evaluation, and Carla, the Director of Curriculum and Training. So before we dive in, I wanted to let you know a little bit about CRUSH. We're located at the University of Denver, and we partner with rural schools and rural school districts. Our vision is healthy, happy children and families living in vibrant rural communities, and our mission is to improve health and education outcomes. Here's a brief overview of where we're headed today. First, we're going to talk about why we do what we do, then how our planning process works, then what happened in the districts where it was implemented. And towards the end of our time together, we're going to share some tools that we've made available for you, and we'll wrap up with some questions and answers. So first, a little bit about why we do what we do. We focus on rural students at CRUSH because rural students face a unique set of challenges, both in terms of their school context, which looks very different from suburban and urban districts, and their behaviors. So for example, rural students have higher rates of engaging in certain risky behaviors like substance use and high-risk sexual activity. And rural children also have higher suicide rates than other kids. And there's many evidence-based practices that schools can put into place to support students' health, but the challenge is helping schools find a way to learn about, select, and get these practices in place. And that's where AIM comes in. AIM is our strategic planning process. We first developed and tested it in 2005, and we're able to show that schools who used AIM were able to implement and sustain more evidence-based practices than schools who used another planning tool. And we've been using AIM ever since in different modes and with different populations, and continue to see that it works. So next up, I'd like to introduce you to Ben, who's going to tell you about how AIM works.
Thanks, Elaine. And as Elaine just mentioned, AIM is a strategic planning process to create district-level comprehensive health and wellness plans, or a CHWP, aligned with the whole school, whole community, whole child model. Many of you are familiar with this, but sometimes we say WISC model or WSCC model. That's what we mean when we say that. So just a closer look at this model. The aim here again is that student in the middle, the green student, and we can achieve that through attention to those 10 components in that blue ring. Models like this are great, but in our experience, it's not enough to just give a school a model and ask them to make their students healthier. Many times they benefit from having a process to implement that model. And that's, again, where that AIM process has come in. So I'd like to walk you through the AIM process, including who's involved, how it works, and what happens after the process, and then some of the results we've seen lately. So first, here's who's involved, a bit of about the key players here. As you can see, this green person is the AIM facilitator. That's someone from our center who guides the school district through the process. Next, this blue person is a wellness coordinator. That's someone hired at the district to coordinate the process from that side of the fence. We also trained these wellness coordinators for this role. And then finally, you have the district task force. This is a group of people who cares about health and wellness in the schools and is recruited by the wellness coordinator and superintendent. We encourage the school to recruit a diverse task force, including teachers, students, principals, the superintendent, and community members. We've seen all different kinds of roles on these task forces, including health department employees, doctors, nurses, mayors, or school board members. So in pulling together this group, they aim for broad expertise across the WISC model and diversity in community roles and backgrounds, with a special focus on historically marginalized groups. Now, here's a bit about how the process works. It starts out with surveys of both the school and the students. So in Colorado, where we've done this work, we have SmartSource, which provides school-level data about the practices, policies, and procedures in the school. This is similar to the SHIPs that many of you may be familiar with. We also have Healthy Kids Colorado Survey, which provides student-level data about health behaviors. This is similar to the YRBS. So if you don't live in Colorado, you can use the SHIPs and the YRBS to complete the AIM process. After those surveys are completed, they get started with meetings. So we have 3 task force meetings in which they assess. Usually when we're in person, I have everybody do this. So if you can see my video, I'm putting an A over my head so you can do it with me if you're really, really behind me. Thank you for co-presenters. A, assess. I, identify. And then M, you can do M this way or this way. M, make it happen. So those are the 3 big meetings of the process. During meeting 1, they look at survey data to assess the current status of student health and evidence-based practices across the 10 WISC components. During meeting 2, they identify which health problems they want to focus on and which evidence-based practices they want to put into place in their schools. And then during meeting 3, they make it happen by developing that comprehensive health and wellness plan. So again, these meetings are all facilitated by that green person there, the AIM facilitator. Another major thread of the process is community engagement. This is spearheaded by the wellness coordinator, that blue person there, along with the task force. There's 2 major touch points of community engagement. First is getting input from students and community members to make sure the plan will meet their needs. This is done through listening sessions, surveys, and community events. Second is the inventory of community resources. This is a chance for task force to do some assets and resource mapping. We encourage attention to 3 perspectives in this. First is who is in the school who may already be implementing the practices and could help them out. Second, who are the partners outside the school that could help? And then third, what financial resources might they need to access to implement the plan? And then this is how it all fits together as one beautiful process. So those 3 task force meetings are spaced throughout the school year, and then key outreach to the community occurs between those meetings. And then this process results in a comprehensive health and wellness plan that is informed by both data and the community. The wellness coordinator and task force create this plan with support from our center. We provide a template to complete these plans, which I'm showing you here, and as well as technical support in populating the plan kind of on an as-needed basis. Now, just a bit about what's included in these plans. There's a background section of where the plan came from, a vision statement for wellness in the district, the student health problems of focus, evidence-based practices aligned to the WISC components, action plans, and accountability and sustainability plans. So now I know you're wondering, what happens then? Well, they implement the plan. Most plans are built out on a 5-year implementation schedule. The task force leads the charge of implementation, with our center providing ongoing support and guidance. So that's the process in a nutshell, starting out with some surveys, pulling together a school district task force who's guided through a series of meetings by a facilitator. Through those meetings, they assess what's going on with students in the school, identify some evidence-based practices to put into place, and then make it happen by creating that comprehensive health and wellness plan. The task force and wellness coordinator also reach out to the community to get input and to leverage resources to implement the plan they create. This process was completed in 1 academic year for each district with, again, a 5-year schedule of implementation to follow. So that's how the process works, kind of in generic terms. Now I'd like to talk about how this played out in Colorado over the last couple of years with support from the Colorado Health Foundation. So this is a map of Colorado. And this red line at the bottom here is the area we targeted. This is a rural frontier region with the highest childhood poverty and lowest county health rankings in the state of Colorado. Just to bring it to life a bit, here you can see to the west is the San Luis Valley, which is a high altitude basin at about 7,500 feet in elevation. And then southeastern Colorado is to the east of these mountains. It's mostly plains, and this is where the Comanche National Grasslands is. So they're both beautiful in their own way. Together, this region is about the size of West Virginia. So we were able to partner with 27 school districts in this region. As you can see, those districts serve over 12,000 students. Just some key demographic info here, about 64% of students are enrolled in free and reduced lunch, and 50% of students identify as Hispanic. Now I have some photos to hopefully bring the process to life a bit. Here we have a task force learning about the WSCC model during the assess meeting. Here they are crafting a vision statement for their work together. Here again during the assess meeting, they are reviewing student data. So for example, they could be looking at the percentage of students who have felt sad, hopeless, or depressed in the last 2 weeks. Here they are during the identify meeting. Here they're prioritizing student health problems. So for example, they might be deciding they want to focus their plan on poor mental health rather than physical inactivity. During identify, they also select evidence-based practices to include in the plan. Task forces typically break into small groups here to focus on an individual health problem and then select practices from across the WISC model that will address the problem they're working on. So for example, if they're working on the health problem of poor nutrition, they might decide to include breakfast in the classroom or cooking classes with families or providing healthy snacks throughout the school day as practices to include in their plan. This is an activity during Identify where we use this giant sticky wall to identify which practices are included in the plan and to verify that the practices included in the plan align with the health problems. It's organized by WISC component up top there, so they can see which components they're heavy or light on, and they can all participate in creating something together. Again, identifying practices across the WISC model here to address the health problems of concern. This is a task force during the Make It Happen meeting. They're mapping resources to determine what they might leverage in their community to help them implement practices across their plan. Also during Make It Happen, this task force is reviewing, this task force is reviewing implementation guidance. So a guide we created to help folks think through the various steps of implementation. For example, getting buy-in from key stakeholders, purchasing necessary materials, or writing the change into school policy. And finally, here's a task force creating action plans. These plans clarify who will champion each practice and the resources they have to draw on to get it done. Again, looking at funding, partnerships, and implementers as resources. So that concludes my little photo section. Now I want to talk a little bit about some of the key outcomes of this effort so far, which are the health problems and practices selected in comprehensive health and wellness plans, and our approach to tracking implementation of those practices. So touching on each briefly here. As a reminder, each school district selected 2 to 5 student health problems to include in their CHWP. This graph is showing how many school districts selected each health problem. So a bar going all the way to the right would mean that every district included the health problem in their plan. The key takeaway here being that poor mental health and alcohol, tobacco, and other drug use were selected as health problems by most task forces, with almost all of them selecting poor mental health as a focus area of their plan. This graph is about the evidence-based practices that were included in district plans. So I'll start you down here in the lower left-hand corner where you can see that 644 total practices were included across the 27 district plans, which is an average of 24 practices per district plan. And then this bar graph is showing which type of practices tended to be in those plans as organized by WSCC component or WISC component. So you remember that blue ring from the WISC model, those are the components I'm referencing here. The message to take away from this is just the most popular component areas were counseling, psychological and social services, and health education. So lots of practices in those areas of these plans. We're also helping school districts track the implementation of practices over time and providing technical assistance to those school districts in doing so. So what I'm showing you here is our implementation tracker. It's just our handy way of tracking if an evidence-based practice has been not implemented, partially implemented, or fully implemented, so that we can provide support to a school district if they're having trouble implementing certain items. Now with that, I'm going to hand it off to Carla to let you know about a few resources we have available.
All right, thanks Ben, and thanks everybody. It's really good to be here. So as Ben said, I'm going to share a few resources that you can access for free. The first one is the AIM Do-It-Yourself Guide, which is a simplified version of the process that Ben just described to you. And the CHWP template, so that's the Comprehensive Health and Wellness Plan template, which is a template you can use to create your own comprehensive health and wellness plan. So we'll provide links to each of these resources at the end of the presentation, and also I think at some point Ben will drop those into the chat box. So check there too, and hopefully you can check those out. All right, the first resource I'm going to share with you is the AIM Do-It-Yourself Guide. So although we ran a highly facilitated process, we really want people to be able to apply these ideas in their own settings. And so we created this guide. So again, we're going to provide links to these. So right now, I'm just going to give you kind of a high-level overview of what's included in the guide so you can get an idea of what you'll find in there. So in the Do-It-Yourself Guide, we include key aspects of the process in a simplified format that we hope can be applied in a variety of settings. So for example, here, tasks to include before the first meeting include things like gathering data, putting together your task force, and then there are some tools available to help you do these things. So you could see here, this is the task force recruitment guide, which will help ensure a diversity of perspectives, backgrounds, and expertise on your task force. So we provide a list of activities for the task force to complete during each step of the process. So if you remember, assess, identify, and make it happen. And you can see those 3 there with the blue, red, and green. And then also guidance about how to include students and the community throughout the process. So this also includes a link to a survey and listening session guide, which you can see there in the red text. I don't know if you can see that okay, but. Also included in this guide is an implementation checklist, which offers suggestions for how to go about putting practices into place. And this is based on the literature of implementation science, as well as our experience partnering with rural schools over time. So the other resource we have available for you is the Comprehensive Health and Wellness Plan template. So again, I'm going to give you just a high-level overview of what's included in this. Okay, the CHWP template includes background information about who, what, and why the plan was created. It provides data related to student health and the school environment, which illustrates how the task force came to their decisions about which health problems they will focus on. And then the template also includes space to list the practices the district will implement related to the different components of the WISC model, as well as a timeline for doing so. And finally, the CHWP lays out the intentions of the task force moving forward to support implementation of the plan. So this includes things like identifying champions, sharing the plan with a wide audience, and evaluation and accountability procedures. So here are those links that I mentioned. You can access both of these resources here at these links. And we'll also drop it in the chat box. I don't know if it's gotten in there yet. I can look.
I haven't been able to punch it in there just yet because I'm sharing my screen.
Okay.
It's
well, be on the lookout. It's gonna.
Oh my gosh, coming soon. Thanks so much, Carla.
Okay. Go ahead. I'm going to pass it back to Ben.
Yeah, so just to close us out for this part, and then we can we would love to look at what questions folks have. Along those lines too, we would love to be able to bring AIM to other states and regions. So if you think your state or community or school would be interested in tackling a comprehensive approach to health and wellness in a school, please don't hesitate to reach out to us, and so we can brainstorm how we might be able to partner. And with that, yeah, we want to invite questions, have some discussion. I'll punch the links in here when I can stop sharing my screen. And then we also want to, I want to thank Carla and Elaine for being such awesome teammates. And it's an amazing team to work on. And I want to thank Asha for allowing us to present here today. Caitlin and Kate have been awesome to work with this morning. So with that, I'll see what questions are, and I'm going to stop sharing so I can put those links in there.
Hi, this is Caitlin. I actually have a quick question about if you've had to make any adjustments or changes since the coronavirus and all of that has occurred, or suggestions to make it easier for people to go through this process while people are apart.
Yeah, off the top. So when we ran this with school districts, we did it before they completed that process before coronavirus, but the coronavirus occurred. Well, I guess the pandemic occurred while we were providing technical assistance. So whereas we were doing in-person school district visits, which we know are important to the partnerships with our rural schools, we had to move to a video conference platform, much as we're all used to now. So those are some of the tweaks we made in timeline wise. Carla or Elaine, I don't know if you have other thoughts on, but I haven't made formal revisions to the process in light of coronavirus. We have had school districts change their wellness teams to be now operating on video conference platforms for those who are not in person.
And just a reminder for people who have joined us, you can ask your questions in the chat. We have disabled microphones just so we don't get a lot of feedback. So thank you for your understanding.
I see Carla has just added the link to the do-it-yourself guide there into the chat. So thanks for doing that, Carla.
Also, Nomita asked, who normally takes the role of champion on campus by role, principal, nurse? So we can maybe, Carla, do you want to take a stab at that one?
So, well, there's, I think, two things kind of wrapped up in that question. One is the wellness coordinator as far as champion for the AIM process. And that tends to, I mean, that I wouldn't say there's a one role tends to take that on. We've had school nurses, teachers, even administrators in some of these small districts take on that role, counselors. Yeah. And then there's the champions for the practices themselves. So that's kind of like the next layer. So within that task force or within that team of people that you're bringing together, we encourage folks to identify champions for the individual practices or kind of WIS component areas so that they can really take on some of those more specific practices. So that's not just one person kind of handling it all, but spread out the work and spread out the energy. And that's every member of the task force.
I'm just kind of working my way down the chat box here. I'm going to pose this next question to Ben. And while I do that, I just want to bring to your attention, Carla, that some people are having trouble getting to that link that you shared. They're saying locked. So, and they're also wanting the other link for the template. So,
okay, well, let me go in and see if I can figure that out.
Okay, Ben, you're up. How are young people and students engaged throughout the process?
So first, I know that Carla's going to be able to change the permissions on that. So thanks for your patience and thanks for bringing it to our
Sorry
attention.
about that.
No worries, because we know we pilot stuff, but then we have the wrong accesses. So, Elaine, your question was about student engagement. So we have a number of different methods that we've used to engage students in the process. One is that we encourage task forces to include students on their task force. And in doing that, we challenge them to not just go to the student council and have the student council members be the voice of the students, but to try to engage students who don't necessarily, have the practice or aren't the ones that adults usually go to, so they can share their perspectives and shape the plan. Another is through listening sessions. We found that wellness coordinators and task forces really appreciate this opportunity to sit down with students from across their school to understand, just from a kind of on a personal level, what their health problems are, what really is not being captured in kind of survey data, what are the descriptive stories about health and wellness in the school, and how might those be incorporated into the development of the comprehensive health and wellness plan. So those are the two big ones that come to mind. We've also had school districts, kind of innovate and create their own methods of getting student input, where they've had kind of individual outreach to students, or they've had kind of more structured reflections at the end of a assembly or an event to get the students' interpretations of key items. So those are some of the things that come to mind for student engagement.
Awesome, thank you. Raul's wondering, kind of in a similar way, how are we promoting parent engagement?
Yeah, so we list parent engagement as among the kind of the roles to try to include on that task force. One way in which this is done in rural schools is many of the folks who work in the school are currently parents, so that's one pathway into it, although that's different than I'm sure what Raul's talking about. The big thing, an effective method on that front has been the listening sessions as well. So those listening sessions have been conducted with students, but also kind of community-wide listening sessions where, they'll bring food and have an event where people can share their perspectives, and we try to provide some structure for getting meaningful input and meaningful perspectives that can be shared back with the task force if those people can't visit. I don't know, Carla, if you have other thoughts on that one.
I'll just add to that I think one of the big things is just that ongoing communication about the work that the team is up to, that the task force is doing, that continues. We kind of throughout the process, encourage the task force to just keep parents updated and kind of facilitate that two-way communication piece. So.
I can take a stab at the next question, which is from
Yeah.
Emily. She's wondering, where do you find student health data? Any recommended resources? So, you know, pretty much every state across the country participates in the Youth Risk Behavior Survey. I hope I'm saying that correctly, YRBS. And so there's a couple of places you can go to find data. One would be your State Department of Education, hopefully has data reports, or your State Department of Public Health might be the keepers of those data. We're really lucky in Colorado because we have access to state level data, but they even break it down by region. So we can go in much more narrowly to a particular geographic area. Also, you can go to the CDC website. They do a really nice job with data findings by year. However, I'm not sure, I just simply don't know, and maybe someone else here would know, and they could put it in the box, the chat box. I don't know how closely they drill down into a particular community. So yeah, in Colorado, what we did is we made an agreement, I believe, with the CDC that we, instead of doing the YRBS, we do what's called Healthy Kids Colorado Survey. It's almost exactly the same, but it just has more protective factors included in the survey. If you want more information about that, just let us know. Next up, Valerie, I think we took care of this. Please add the link to the CHWP template. Does that seem to be working better now? All the links for that and the other thing? I think so. You'll tell us if not.
Thanks, Valerie.
Okay. Sarah, thinking about ongoing activity sustainability, how often is this process repeated? Annually, every 3 years, etc.? And how is this linked to the federally mandated local wellness policy or other policies? Thanks for sharing this fantastic model. Who wants to take that one?
So I can take the certainly the first part, which is we have there's been limited examples where this process has been done more than once. We've done this process at the school level, and also the version we just went through is done at the district level. So we've had kind of separate processes at different kind of angles on a school district or a school. One thing we have is kind of quick and dirty update agendas where a task force or a wellness team can look at where things were in their comprehensive health and wellness plan, take stock of you know, what has changed, what needs to be amended, and then we have kind of a template for an annual addendum or amendment to the CHWP where they might reorient or refocus their efforts and have, you know, changes to what the practices they want to be implementing. So I think that will address the first version of it. We would just love to continue to do it every year, but we there's a limit to how many processes folks can participate in. And then how it's linked to the federally mandated LWP or other policies. Elaine, you want to talk about that one? I know you know this better than I do.
So you all can also help me make sure that I'm staying current. But, you know, initially when the local wellness policy mandate hit schools, I think it was like around 2006-ish, and it was just limited to physical activity and nutrition. I forget if it's been expanded beyond that. And maybe Carla and Ben, you can just keep an eye on the chat box if anyone's helping us know if it's been expanded beyond that. My understanding is that some schools have been able to take their comprehensive health and wellness plan to their school board and get that approved to get like as an addendum to their local wellness policy. But the local wellness policy, you have to include, you know, specific plans for evaluation, et cetera. So sometimes like both documents are needed, but they're very overlapping. And I don't know, Carla, do you have anything you want to share about that?
No, I think that's basically it. Yeah.
Okay. Nomita, let's just see, did anybody, no, okay. So Nomita says, thanks, great information and work. Do you have future goals for scaling up to all schools, not just rural? You want to do that one, Ben? Or do
Yeah. So we've found a bit of a niche with being, I guess, successful in rural schools. And we have done this in bigger school districts, and have lessons learned through that about what it means to make district-wide change in health and wellness at a big district versus what it means at a small rural school district. So right now, this version of the process that you're seeing today is reflective of that small rural school district. I think big district changes would require a different process. That being said, I think some urban schools in and of themselves are bigger than some rural school districts. So I think there is definitely potential for applying the process at the school level. That's my general take on it. Aspirationally, we just want to see kids happier and healthier. So anywhere which is part of why we are super excited to have links that work to everybody, and that's going to happen. We want people to be able to take this and run with it. So wherever it ends up, we would be excited about it, I would say.
And if you are interested in potentially partnering with us to do this kind of work, please reach out to us because we would love to talk with you. All right, moving on. Carla reposted the links, which we think are working, plus Asha is going to make sure that it's on their website as well. Katie, if a school district doesn't have a wellness coordinator or task forces, how do you get buy-in from the school and district? Thank you so much for the Google link.
Carla, you want to tackle that one?
Sure. So I'll say that, preface this by saying that when we started this process, there were no wellness coordinators at the districts that we were working at. So this was like their first foray into being a wellness coordinator. And for some of them, this was the main thing that they did as wellness coordinators. So I'd say that as far as the process itself, you really do need someone at the district who's just coordinating at that level. And whether you call them a wellness coordinator or whether they're, another person at the district who's just taking this on as an added, project, you really do need somebody there, because that element that Ben talked about when he was going through the AIM process of getting that community engagement and engaging students, putting together the task force, you really just need someone who's in the school doing that work. So I don't know if anybody else wants to talk about buy-in as far as getting buy-in from the school district, but to maybe make room or space for somebody to take that on.
One thing, and I'm sorry because I was navigating the chat box, so I'm sorry if you already said this, just interrupt me if you already did, Carla. I think it's been strategic to tell administrators that by doing AIM, they are going to be in compliance with state and federal mandates. Did you already talk about that?
No.
Okay. So, for example, in the state of Colorado, we passed a law a few years ago where you had to demonstrate that you had 30 minutes of any type of physical activity happening each day in school. And this was a new law, and it's so frustrating for a lot of our schools because they just feel like it's one more thing that they have to demonstrate with no funds, blah, blah, blah. And so we were able to come to them and say, look, if you go through this process, we're going to be able to help you demonstrate that you're in compliance with that particular mandate, as well as the local wellness policy mandate. So I feel like that's a helpful strategy. Ben, do you have anything else?
Yeah, I mean, I would also say that the honoring the context in which folks are working, in rural schools, folks often hold multiple jobs and have no time. The teachers are driving the bus and the principals are superintendents. So I think honoring that and respecting that context it has helped us to kind of communicate that we have a process that doesn't waste any time, and then it involves everybody, and it's going to be aligned with their mission and vision of really, if you can remind folks why they got into education, that they care about, you know, the kids that go to that are attending the schools, and that health and wellness isn't, you know, an add-on or an aside to their education, but it's part of it. You can kind of get aligned with the mission and vision of the school. That also helps.
I love Valerie's question. It's coming to you, Ben. Can you share one or two impactful evidence-based successes?
Thank you, Valerie. I mean, the ones that I guess that strike me as most impactful are the ones that are gonna, you know, we like changes that are gonna stick around for a long time and be a lasting, you know, device of health promotion in a school. So we love changes that are structural, that can't be taken away when people move on. So one that I really like that is, you know, we had a school where they didn't have clean drinking water for kids. So they had jugs of water out in the hallways. And that's kind of, it was replacing these jugs of water out in the hallways. That was the way that the kids, you know, had access to water. And so they were able to put in a new water bottle filling station, which was filtered and it had safe water for the kids, which was a huge, you know, a huge win for every kid who's going to be in that school right now, and every kid who's going to be in that school until the filters run out, I guess. So some of the ones like that are the ones that I really love. Other ones are, you know, new playground equipment to get kids moving, and to ensure that they'll be moving for a long time. And you know, another big impactful change has been the start of a culture shift in a lot of rural schools. You know, we've partnered with schools where they didn't have a wellness team, and then they do the AIM process, and then that you know, that finds out that come to find that there's a group of folks who are motivated and excited about promoting health and wellness in the school, and they continue to convene on their own for years running. We've had some school districts, you know, going 5 years back now, who just have their own wellness teams because they went through the AIM process, and that kind of, it was a spark that got people excited about promoting health and wellness in the school. So those are some of the ones that stand out to me. I don't know, Carla, if you have other favorites.
Yeah, no, I was thinking exactly that culture shift is one thing that I've definitely noticed, that having wellness teams that meet regularly and looking at data is another thing that I think that those teams are doing now. Like that earlier question about how often do you do this, and Ben, you mentioned this, but I think a lot of our districts who went through the AIM process this year looked at their new data, and we're kind of using that to inform what's happening this year. So I thought that was a really big thing. Also, as far as different practices, health education, and I think that came up in an earlier slide, was a really big one for our districts. The vast majority did not have health education programs, and have or are in the process of implementing those. So
my favorite evidence-based change of all time lasted about, I think, maybe 12 years. So it's kind of getting back to Ben's point, that he likes changes that stick around. And that is one where the school decided to build a half-size basketball court outside, which added a whole nother way that kids could be active during recess. That's a very nice example of a permanent change. The only reason that it only lasted 12 years is that school got a grant to build a brand new campus. So the basketball court went away. Okay.
One other thing I'll say on that is just the CHWP itself has been used as a grant proposal to get some of the funds for some of the things we're mentioning are pretty expensive. New waters, fountains, and new basketball courts are expensive. So we've had school districts who just use that CHWP as the central artifact of a grant proposal and cause for needing funds, and that's you know, so far been met with, you know, with some success. Because we've got, you know, they can show that they went through an intentional process that was community engaged and data driven, and now they have these needs because of that process. So there's a strong rationale built in there. Back to you, Elaine.
That's a very good point, Ben. Okay, so Sue wants people to know, in terms of ways to find data, the YRBS, the School Health Index, and county health data. County health data is a really good place to go to get teen pregnancy rates. Okay, people asking to reshare the links, which I think we've done, and Caitlin's going to be sure to get the correct links out to everyone in the email that you'll get after this. And there's the CHW template link. And is the comprehensive health and wellness plate template available in PDF Google link as well?
Yeah, so you should be able to access a link to the CHWP inside the do-it-yourself guide, but we can also be sure to include that link here. And that file is built as a because we want people to be able to take that template and run with it. So it's built as a Google Drive document that you can copy and then edit your version of that copy. But Katie, if you want it as a PDF, we can definitely include that too. We can don't hesitate to reach out to us.
I was just going to say that if you click on the link, it should take you to the Google Doc. It looks like people are in there, so I'm assuming that you're able to access it, that one, okay. If you go to File and make a copy, then you can add it. You won't be able to edit it as it is from that link, but File, make a copy, and then you can add it to your own Google Drive or download a copy in Microsoft Word.
Well, I believe we made it to the end of our questions in the chat box. So if you've got one on the tip of your tongue, I believe this is the time to put it in there because we could get an immediate answer.
I'll also put our email addresses in the chat box. So if you at any point want to reach out to us, please do so. I'll do that now.
Ben, Elaine, and Carla, thank you so much for sharing all about this process. This was wonderful. I'll give everyone just another minute or so if you have a question, just to make sure we don't miss anyone. But if not, we can start wrapping up. Carla, thanks for adding your emails into the chat box. I'll give everyone just another 30 seconds or so.
And just a reminder, this is Caitlin. A post-webinar email will be going out that will include a link to the recording, to today's slides, as well as any other resources that we'd like to share today. So keep an eye out for that. Should go out later this afternoon, if not tomorrow morning.
Thanks for reminding everyone, Caitlin. So just as a reminder, I said this earlier, but ASHA provides continuing education credits, which is wonderful. So today is eligible for one continuing education hour, and you get them by completing the webinar evaluation. So definitely complete that if you need that. Very smart of ASHA to do that. So hopefully we'll get some good evaluation data from this webinar. Excuse me, an upcoming webinar is on November 10th, integrating physical activity into the classroom, practical strategies for all school health leaders. I'm personally very excited for this one, mostly because I'm leading it. So ASHA does just a wonderful job pulling together lots of different webinars over the year, over the course of the year. And so if you've enjoyed this one, I hope you'll join us for the upcoming one in November as well. And I'm sure more information will be coming out about that webinar as we get closer to that date. And with that, thank you again so much for joining us. Caitlin, please pop in if I'm missing anything, but we hope that you visit us online. Give us a call if you need anything, and other ways to connect with ASHA are there on the screen. But if not, I hope everyone has a fabulous rest of your day and stay connected with ASHA.
Yeah, and just another real quick note, November's webinar is our last webinar on the schedule for 2020, but we do have our call for webinar proposals open now for 2021. So if you're interested in presenting a webinar we'll have information up on our website, and then hopefully in February or so, we'll have our schedule for 2021 available. Hard to believe we're almost there. But thank you all for presenting today. It was a great presentation. And again, keep your eye out for that email, and have a great day, everyone.
Thanks so much, everyone.
Thanks, everybody.
Thank you. Don't forget to vote.